गणाधिपाय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि।
Good evening to all the doctors. Good evening to all the delegates who are with us for this wonderful evening. We are hosting a webinar on implantation in association with Indian Fertility Society, Puducherry chapter. On behalf of Shield Healthcare and Shield Connect, we would like to thank Dr. Papa Dasari Madam for giving us the opportunity. Also, we would like and welcome two of the eminent speakers, Dr. Priya Kannan ma'am and Dr. Mariano from UK, who will be giving us an insight on on this webinar on implantation. Also, I would like to thank Dr. Chitra ma'am, Treasurer IFS Puducherry, and Dr. Jisha Rajendran sir for giving us an opportunity to hold this wonderful webinar. Thank you so much, doctors, for logging in for this evening. So I would like to hand over the session to Dr. Chitra ma'am.
Yeah. Thank you very much. Good evening all. I just on behalf of the committee, I'd like to welcome you all to the Indian Fertility Society Puducherry chapter who are conducting a webinar on the very important topic that's very crucial for the process, that is the implantation. So as everyone knows, implantation is a very important thing, the process which occurs for the implantation of pregnancy. It can be spontaneous or it can be an IVF pregnancy. Actually, the two important components of implantation is the one, the embryo, which has a potential to get implanted, and one is the receptive endometrium, which has to enable the implantation. So the crosstalk which occurs between the embryo and the endometrium, it leads to its attachment and invasion. So today we have experts with us, Dr. Priya Kannan and Dr. Mariano, who is going to tell us about what is the crosstalk which occurs between this embryo and the endometrium, which results in successful pregnancy and which might also result in unsuccessful, and how to go about it. So welcome you all. So I request Dr. Dasi Papa, who is the secretary of the IFS chapter Pondicherry, to introduce the speakers. Over to you, ma'am.
Okay, good evening. And I thank the speakers, Dr. Priya Kannan and Dr. Mariano. To introduce Dr. Priya Kannan, she has been and she will continue be as my teacher in embryology and reproductive medicine. I have great honor to introduce her. She is the past president of Academy of Clinical Embryology India. She is currently the director of clinical embryology, Garbha Rakshambika Fertility Center, where I have undergone a 6 months fellowship. And she has got both beauty and brains. She is very innovative. I found her as a very good administrator. Everybody in the center are scared. They are up to date. They are very perfect in their work. And she's a very, very good daughter. I told her I would like to have a daughter like her. And she's so supportive to J.M. Kannan Madam, one of the Dions in the reproductive medicine. So she has got various awards in her UG, community medicine, ENT, pediatrics and general surgery. And also she has received very honorable prize of Professor Nanjuda Rao Prize for highest marks in surgery. And she has done her master's in clinical embryology from Monash University, where the first IVF pregnancy, though unsuccessful, has occurred. So she is a very busy person, and I thank her a lot for accepting our invitation. And another thing I want to tell, she is very instrumental, very helpful in starting the IVF lab in Jipmar, Puducherry. She was the first person to come and help us to validate all our equipments and start the lab function, give her inputs, what to buy for the IVF lab, what are the drugs, consumables, and how to keep the records. And there are no words to thank her for all the support she has given us to start our IVF lab at JIPMA. I welcome you, Dr. Priya. Please go ahead without wasting any time with your talk. And she is going to talk on quality of embryo in implantation.
Thank you so much, ma'am, for that wonderful introduction. And I think I feel humbled, and madam, you saying such words is just really humbling, ma'am. And I'm honored to have been with you, and I'll continue to be with you, ma'am. So I'm just going to talk today on, okay, I think I ran through my slides in between, so it's in the middle. Okay. I would be talking on embryo quality and implantation. So just a second, I'm just going to move this the way. Yeah. So we all have had a lot of thought about it. We have assumed a lot of things about embryo quality and how it could be related to implantation. But there are some dictums as well that would remain the same in terms of certain things. Let us just see, as we have seen beautifully during the COVID times, how evidence-based medicine actually progresses through, right from having a question to work through it and then revisit the answer and then see if we can have a better answer. The same way, the correlation between embryo quality and implantation is not static. It is something evolving, and we are getting to know a lot of information as things go by, as more technology is coming up. The first and foremost, which we knew and we have assumed and we have always thought that is going to be there, and we are using it daily in our practice, is that the morphological criteria, which we use extensively even now to select embryos at cleavage stage, are insufficient to predict their developmental potential, notably the euploidy status of the embryos as well. Now, yes, though this has been, we know that this is there at the cleavage stage, there is some issues that we cannot address, but still morphology continues to be the most important basis on which we grade embryos. To start with, to give a slight amount of history, I think we all knew that embryo has to grow at a particular stage to reach, but there were two important milestones which were put forward at various points of time. One was Payne, who brought forward the pronuclear staging. I think she was the first one to do time-lapse imaging as well. She kept cameras inside the incubator to see how the pronuclei happens and how it splits and what happens and everything. I think it was just a marvelous thing to do way back in 1990s, early 1990s or late 1980s. So she came around and said, she proposed a certain patterns of pronuclei distribution, which definitely we are using even till today, which can improve which we use to grade the pronuclei. And that is the first thing where we said, okay, if it is there, your implantation rate, the chances of these embryos growing to a blastocyst and hence implanting will be higher. The next one, which we came around late 1990s or early 2000, was the checking of the early cleavage. That is, if the embryos cleave at 24 hours post-insemination, then the chance of implantation is high. These two are historically marked as two important aspects which have contributed to the grading of embryos in relation to implantation. And then we had the PGS1 and now we have the PGS2. And then there are lots of happening, like we have moved from cleavage stage embryos to blastocysts now, though a lot of clinics, even we do a lot of cleavage stage transfers, depending on how the patient is, how the embryos are. But let us just revisit this question on how is the embryo quality correlating to implantation. So I went ahead and I didn't want to present anything which was like beyond much before 2010. So I said, I wanted to see what is happening right now in this era of PGT. How is it happening? So this was a great article, which publication which came around, which says, from the fertility sterility, morphological grading of euploid blastocyst influencing implantation on ongoing pregnancy rates. So this particular paper, they had compared excellent quality to poor quality embryos, and this was their conclusion, that the excellent quality embryos yielded a statistically significant higher implantation rate compared to good, and then much lesser was the average, and then came the poor quality embryos. So this is something we have always known, and which is something being reiterated again by this publication, which said that the implantation rate is the best is the excellent quality, next would be good, and then average, and then the poor quality embryos. The excellent quality embryos yielded a significantly higher ongoing pregnancy rate as well. So every paper we see, there will be a distinction of biochemical pregnancy rate, clinical pregnancy rate, ongoing pregnancy rate, and then live birth rate. So we need to be looking at everything. So the biochemical pregnancy rate, and then the implantation is when we look at BC, actually the sacs on the scan, and then we say, yes, the embryo has implanted. So they had also come to the conclusion that excellent quality embryos yielded a statistically significant higher ongoing pregnancy rate, more than the good quality embryos, which yielded more than the average quality embryos, and which yielded or more than the poor quality embryos, which we can see from which all of that was statistically significant, which is nicely represented pictorially by the authors. In terms of embryo quality and spontaneous abortions, they also could see from their data that poor quality euploid embryos were associated with a statistically significantly higher rate of spontaneous abortion rates, which was more than that of the average quality embryos, more than the good quality, and much the least was found in the excellent quality embryos. So that is something we have known, and we are always apply that in our practice. So this is one recent paper which has again reiterated the same. Now to see if there is any, in terms of blastocyst, whether the cleavage stage, whether there is a correlation between the blastocyst and the cleavage stage. Well, we all look at cleavage stage and then we take them, we decide to take them to either blast or no. And there are some clinics which don't do any cleavage stage transfer, they do only blastocyst transfers. So in that case, is there some, if we have like 10, let us say BB or AA or AB blastocyst, is there some way that we can see which embryo can have a better implantation by this and not by an AI? This was a retrospective study which had a huge number of embryos, 3,386 single vitrified worm blastocyst transfer cycles. They had grouped the embryos in blastocyst stage to group 1, 2, 3, and 4. And the question was to study the effect of the cleavage stage embryo quality and embryo development speed measured in terms of clinical pregnancy rate and live birth rate. I'm taking here the clinical pregnancy rate and that as a measure of the implantation. So what did they find? They also found that the highest biochemical pregnancy rate was observed in group A, which is where the embryos had, the blastocysts had the best of the quality of the embryos as compared to group B, which is the second grade BB, and which was more than the group C, which is BC, and the group D, which is CB. The same trend was also found for clinical pregnancy rates and the live birth rate. The post-hoc analysis showed that these rates in the group A were higher than in the group B, and the rates in BB group were higher than those of the BC and CB. These are the subgroup analysis. Just we say that AA, AB, and BA are group 1, and BB, BC, and CB are group 2. So just to have a subgroup analysis. The miscarriage rate increased from group 1 to group 4. So the lowest was here, as we can see in the live birth rate, the lowest was found in the in the best quality of the embryo, the top quality blastocyst, and it increased steadily to the poor quality blastocyst. That's a very busy slide. We'll just move to the next one to see what actually conclusion we have. The proportion of the day 3 blastomeres, cell number with less than 6 blastomeres, increased from group 1 to group 2 to group 3 to group 4, which means that if we see a embryo on day 3, which has less than 6 cells, but they also can go ahead and have become a blastocyst on day 5. So if the number of embryos which had less than 6 blastomeres on day 3, which went on to have a blastocyst, the less of them were in the top quality. So this is a very important indicator to see why we need to check on day 3, just to make sure that we see, and then you can also separate and keep those embryos to see how differently they are, and easier for us to do a selection of the embryo on day 5 as well. The proportion of day 3 embryos having a blastomere of more than 8 was maximum, obviously, as expected in the top quality blastocyst. The embryo development speed showed a slow trend towards these group, which is a proportion of the blastocysts frozen on day 6. So whichever had a poor or a lesser development speed, that is a cleavage rate, had blastocysts frozen on day 6 and not on day 5. The group 2, which is the BB, BC, and CV blastocysts that were frozen on day 5, had significantly better clinical pregnancy rates and live birth rate than those frozen on day 6. That means, which means to say that the cleavage rate or the embryo development rate is significantly affecting, has got a significant rate of affecting the clinical pregnancy rates. Except for those embryos which were frozen on day 5, the day 3 blastomere number, which is the cutoff here, was found to be more than 7 blastomeres. For the blastocysts having a grading of CB group in the live birth rate and the blastocyst degree of more than B4 for the BB group in clinical pregnancy rate, they're also important factors, which means the number of blastomeres on day 3 and the expansion of the blastocyst, which is a blastocele size, was important factors. The BB grade blastocysts in group 2 and BC grade blastocysts in group 3 with blastocysts frozen on day 5 resulted in a higher live birth rate than when they were frozen on day 6. The CB grade blastocysts in group 4, the live birth rate was significantly higher when the same graded blastocyst was frozen on day 5 as compared to day 6, and also when the day 3 embryos showed more than 7 cells. So I know it's slightly confusing, but then the crux is this. On day 3, if the number of cells is more than 7, then even if the embryo is, and if the embryo is frozen on day 5, the same has got better implantation rates than when the embryos has less than 7 cells on day 3 and if they are frozen on day 6. However, we'll be coming to another paper which is totally contradicting the same. So the conclusions that we can take from this paper which were arrived was clinical pregnancy outcome worsened from top quality to the lower quality blastocyst grade, and the proportion of the embryos with a better cleavage stage embryo quality and faster development had better top quality embryos and hence better implantation rates. Among the best grade blastocysts, neither the number of the blastomere or the degree of cytoplasmic fragmentation on day 3 had any effect on the pregnancy outcomes. Only the blastocele size was an important factor in this. Again, the embryos that were frozen, even if it was BB, BC, or CB, on day 5 had better clinical pregnancy rate and implantation rate than when they were frozen on day 6. The blastocysts which were CB, which is a poor grade blastocyst, when they had more number of blastomeres on day 3, had a better clinical pregnancy rates than the same grade blastocysts on day 5 with less than 6 blastomeres on day 3. So that brings us to the point. should we even think of transferring poor quality embryos? If we have no other embryos, but you have only poor quality embryos, are we supposed to throw them away, or can we actually use them? This was a very nice paper which had about 738. They had compared 738 poor quality embryos from various programs to a control group which had 9,893 fair or good quality embryos. So here we can see the data where the number of embryos they had transferred, was about, it's the same. And the clinical pregnancy rate, this is on day 3 transfers or day 5, comparing poor quality embryos or day 3 and day 5. So the number of embryos were the same. The biochemical pregnancy rate was also similar. The implantation rate is also similar. The clinical pregnancy rate, live birth rate, miscarriage rate, everything was almost similar in the poor quality embryos transferred in either on day 3 or day 5. But what is good to see is that they still have some implantation rate. So about 6% or 7%. Instead of throwing them away, I think that is a good way at least to counsel a patient and then use these poor quality embryos if they are the only one left for us.
Dr. Priya, just 1 minute. Can you please explain this implantation rate, clinical pregnancy rate to the PG sick? Just because general obs-gyn also joined.
Sorry, ma'am. I thought I just...
No, just here in this slide so that they do understand.
Yes. So implantation rate is when, how do we calculate the implantation rate? It is the number of sacs we see on the ultrasound divided by the number of embryos you've transferred. And that is our implantation rate. Clinical pregnancy rate is when you see the FHR. And that's how we do the clinical pregnancy rate, when it becomes an FHR and continues. And then ongoing is after 12, and then live birth rate is when we actually see the baby. So the implantation rate is a very important factor for determining the quality of the embryos and the quality of our IVF lab as such, because the rest of it can be because of various factors. After 12 weeks, there can be PIH or something affecting the pregnancy. But then the number of embryos that actually implant and show us a gestational sac is an important parameter for us from the embryology lab. So we always are interested to see if I have transferred 2 embryos, do I see 2 sacs or just 1 sac? So that is a very important parameter that we always are looking for in every result that we are looking. So miscarriage rate, obviously the number of miscarriages we have over the number of, the implantation rate is, the denominator is fixed. It is the number of sacs divided by the number of embryos we transferred. Whereas for clinical pregnancy rate, live birth rate, and miscarriage rate, or even biochemical pregnancy rate, the denominator can be your number of embryo transfers done, or number of pickups done, or number of stimulations started. You can have it as tough as possible. The easiest would be to have it over the number of embryo transfers performed. Is that okay, madam?
Yes, thank you.
Thank you, madam. So it is good to know that some of them actually had implanted. So this is another comparison of poor quality embryos as compared to the good quality embryos. The mean number of the embryos transferred were the same, but as you can see, the difference in between the poor quality embryos, the biochemical pregnancy rate, implantation rate, clinical pregnancy rate, everything was lower than compared to the good and fair quality embryos transferred. However, we can see that here the miscarriage rate is also lower in this particular study. You see it's 2.2%, here it's 6%. So, but if they have implanted and then there is no spontaneous abortion, we see that the live birth rate has no statistically significant difference. It's about 79% to 79%. So once implanted, they probably do better till the end. So the probabilities of pregnancy development from one sequential stage to another after a poor quality embryo and compared to the transfer of good quality embryo. So the poor quality embryos have lower probability of biochemical pregnancies, but if they implant, they have the same potential for development and live birth rate as good as the fair and good quality embryos. So this large study also concluded that Yes, poor quality embryos can be transferred, and on day 3 or day 5, they have the similar poor outcomes. The clinical pregnancy rate was higher for blastocysts of a low quality compared to a low quality cleavage stage embryos. The transfers of embryos of low morphology do not increase the rate of spontaneous abortions. And after implantation, both a good and a poor quality embryo has the same chance of a live birth rate. So we have another one where we had a comparison of using whether these good and poor quality embryos, if they are found to be chromosomally normal, does it improve implantation or it has got no impact on the implantation? It is by the famed Laura Renzi and group from Italy. So the study question here was, does conventional blastocyst morphological evaluation actually correlate with euploidy by comprehensive chromosome screening of the trophectoderm, and does it have any effect on the implantation potential? It was an analysis of about 956 blastocysts from 213 patients. And here we see that the euploid embryo, implantation of the euploid embryo and the implantation rate. The blastocyst grading was poor. This is the grading based on morphology. These are the implantation of the rate of implantation of the euploid embryos. So when the morphology was poor, still if the embryos are euploid, they still had the same implantation rate as compared to an excellent morphological graded blastocyst and a euploid. And it's this combination of euploidy it seems to be the most critical in this. But however, there are controversies in this, which we will not go to at this point. So the take home is that when it's a euploid embryo, the implantation, whether it's a poor or an excellent quality embryo, it seems to be the same. There is, however, the increased aneuploidy rate among the blastocysts with poor morphological score and a greater likelihood of the euploid embryos to have a much better morphological score. Another thing that the study also studied, like the one we had earlier, is the timing of the blastulation. That is the size of the blastocyst. The developmental potential of a euploid embryo reaching the blastocyst stage at different days post-fertilization was similar, with 48 and 51% of day 5 or day 6 blastocysts, yielding an ongoing similar pregnancy rate. The day 4, they had 4 day 7 euploid embryos transferred, which also gave them 50% implantation. But here we have to mention that this study actually had a comprehensive chromosome screening of all the embryos, and they transferred only the euploid. Whereas the study we had before did not do the CCS, and hence that is a major one step higher than the studies we have seen before. The embryos reaching the expanded blastocyst stage on day 6 showed a similar risk of being aneuploid as the one which reached the blastocyst stage on day 5. The evidence suggests that the timing of blastocyst formation may not be linked or affected by the chromosomal abnormalities. So, but then we always have this doubt. We are transferring poor quality embryos. It can probably have the same chance of going through and having a live birth rate as that of a very good quality embryo. But would this increase the chance of congenital malformations or chromosomal abnormalities or any of those adverse effects that we don't want to see in an IVF baby? This case control study had about 74 children who were conceived by IVF or ICSI, exclusively from the transfer of very poor quality embryos, and they were compared to 1,507 children born after the transfer of only top quality embryos at the same period of time in same centers. They found that the prevalence of birth defects in children resulting from very poor quality embryos was 1.35%, which was similar to the children who resulted from top quality embryos, and the percentage of birth defects was 1.72%. So, and the rate of chromosomal abnormalities detected was also similar. So congenital malformations or perinatal complications does not seem to be more common in children born after transfer of very poor quality embryos in IVF or ICSI cycles as compared to the children born through transfer of only top quality embryos. So I'm just going to give a gist of the take-home messages because I think I've confused all of you enough. The morphological criteria, which is commonly used to select the embryos at cleavage stage, is insufficient to predict their developmental potential, which is why whenever embryos are available to a certain extent, that is, you have 3 or 4 good quality 8 cells, that is having more than 7 cells on day 3, you can choose to go ahead and have extended culture and culture them to day 5, day 6, or day 7. Right now, what the shift is happening is that we don't throw any embryo out unless it is an arrested embryo until day 7 of culture. Even if the embryos are there, if it's a good quality or a poor quality blast on day 7 also, we choose to freeze them down for future use. And as we have seen from the previous slides, that they also seem to have a good chance of implantation as well. Dr. Dean Morbeck has extensively studied and presented that as well. You can search his name. And yes, I wanted to present, but then I didn't want to overshoot the time. So I just thought I will mention that in the presentation. We can definitely look at the messages, the publications he's done, and the data he has put out. And so for the past, I think 3-4 years, we have not thrown out any embryo until day 7. The pregnancy rates are higher with the top and good quality embryos. The spontaneous abortion was higher with poor quality embryos. The embryonic factors have less role to play in top quality blastocysts. That is, embryonic factors meaning such as the number of blastomeres on day 3, fragmentation on day 3, they seem to have a less role in top quality blastocysts. In poor to average quality blastocysts, the blastomere number on day 3 can help in selecting the embryo. So an embryo which had more than or equal to 7 cells on day 3 has a high implantation rate in a poor or average quality blastocyst on day 5. The clinical pregnancy rate was higher for blastocysts of low quality compared to low quality cleavage stage embryos. The euploid blastocyst, whether it is good or poor quality, had same or similar pregnancy rates, but more aneuploidy was noted in blastocysts with a poor morphology. So an embryo, a good quality, the availability of good quality blastocyst on day 5 or day 6, day 5 particularly, is definitely a mark of the culture systems in any IVF lab. The first sign that we will have that there is some problem in the culture system is when we start to see less and less number of top quality blastocysts on day 5. When it's the percentage of that starts reducing, that is the time we have to start looking at the culture system. Before, I mean, the result of biochemical pregnancy rates comes 15 days later. By that time, we would have had so many patients go through our culture system. So the fall in the percentage of a top quality blastocyst on day 5 is the first indication to look back on our culture system. The developmental potential of euploid embryos reaching to blastocyst stage at different days of post-fertilization was also similar. The prevalence of birth defects in children resulting from poor quality embryos is similar to that of top quality embryos transfer. Thank you very much for this opportunity to speak to you all. And I'll be very happy to take any questions.
Thank you, Dr. Priya, for that excellent deliberation of a very high level talk, I would say, for our postgraduates too. But a few basic questions. What are the factors that affect embryo quality? Like, when do you get excellent and top quality embryos, and what are the factors, adverse factors that result in poor quality embryos? Does the chromosomal makeup has anything to do with the poor quality embryos?
Ma'am, in a culture system, there are about 200 variables in our IVF culture system, which starts from the patient egg and their particular thing. So we're looking at, in the IVF ART program, we're looking at about 200 variables. So a poor quality embryo can be from any of these, but primarily we have to look at the egg, which contributes to about 60% of any embryo quality. So the egg means the intrinsic factors in the mother to our stimulation, but of course, everything in the culture system, such as how we maintain the temperature, the CO2, how our incubator is maintained, the handling of the embryos, the air quality, everything will affect and can have an effect on the quality of the embryos. But of course, ma'am, we have seen from many papers and from the papers I presented as well, that an embryo which is euploid, the probability of that becoming a top quality blastocyst is quite is not as good as a it's only a euploid embryo which has got a higher probability of showing as a top quality blastocyst by morphology as well. An euploid embryo, the chance of it showing as a top quality blastocyst is lesser than that of a euploid embryo.
Yes, that do you mean to say that when the morphology is top quality, the chances of chromosomal abnormalities are minimum? Does it translate to that understanding?
Yes, ma'am. That is what the papers are saying, that it can be less. But definitely it's a subjective thing. It is not an objective one, because we have not gone ahead and tested the blastocyst. When we test, there are some papers which say there is absolutely no correlation, but there are some which says that the top quality blastocyst definitely will have lesser aneuploidy rate than poor quality blastocyst.
Because it is not possible for us to test every embryo for PGS or PGT. So this morphological classification is an important step in counseling the patient. How exactly, little bit, I know you are a very good counselor, how exactly you counsel the couple after after the embryos are graded, and in explaining the implantation rate, or they're not worried about implantation rate, they're worried about live birth. How exactly, just a few things, I know it is a very extensive topic, just few tips for the postgraduates when they talk. They are the ones who talk to the patients most often.
Yes, ma'am. The first and foremost that we always tell the patient is that a top quality embryo has a higher chance of implantation than a poor quality embryo. Having said that, if there are only poor quality embryo left, then we tell them that it is not that they have nil chance of implantation, but they do have about 6 to 8% chance of implantation. And hence, if there are no other embryos left, we can choose to transfer them and wait for the result. Because as we know, some of the poor quality embryos can also be euploid, and we may be throwing out euploid embryos in that case. So that is one, ma'am. The first thing that we have to always have and counsel the patient is a top quality embryo always has got a better implantation potential. The poor quality embryos, if there is a mix of top and poor quality embryos, we would preferably not save all the poor quality embryos in one particular cryo. I may keep one with another one good embryo. There was another interesting paper which actually looked at if they had frozen, it was all an FET cycle, they had frozen one good and one poor quality, and two good embryos and two poor quality embryos. Actually, they had a very good implantation rate when they had chosen to transfer the ones they had transferred in with one poor and one good quality embryo. So you can combine that instead of throwing it away as well, because I think as embryologists and as all IVF clinicians, an embryo is a precious thing. We don't want to just throw them away. Unless it is arrested, we don't throw them away. We always like to either transfer or freeze them. Even if it is poor quality, there's as I said, even on day 5, it is a CC blastocyst, it still has got 5 to 7% chance of implantation. A 7% chance of implantation is pretty good than throwing it away. So that is something we always need to tell the patient. Once we are convinced that even a poor quality embryo has got about 7 to 10% chance of implantation, we will be more convinced to talk about that to our patients as well, so that they don't throw away the embryos. They don't say, no, madam, I don't want them, just throw them away. That we have to put it across to them that way, that they also have a chance of implantation.
So to say that poor quality embryo is nothing to do with the live pregnancy rate, do we tell them like that?
Poor quality embryo has got a poorer chance of implantation. Like a good quality embryo will have what 40% implantation rate. This will have about 7 to 10% implantation rate. But once implanted, that is what the data says. Once they've implanted and you see a clinical pregnancy rate, the chance of that pregnancy going ahead with the live birth rate is the same as that of a pregnancy which has resulted from a top quality embryo.
So most often, just my last question, patients would ask, when we say you got a very poor quality embryos, they do ask us, how should we improve the quality? Is it only the patient factor? How to answer that question, that any drugs to be taken, or what I should do to improve the quality of my embryos? I know it is both man and woman, the sperm and as well as the oocyte. But women do ask this question, how to improve, doctor, my quality of the embryo? What I should
embryo
do?
quality, the improvement of embryo quality starts from the couple themselves. We need to improve their from nutritional status, madam. In our country, nutritional status also plays a major role. So from nutritional status to giving them antioxidants to CoQ, that is on their side. However, if you are looking at somebody with a very low AMH who will give very less number of eggs to us at an older age, then that is probably the crux where we can't do anything much at all. But however, even if it's low AMH, they are younger, the embryos tend to have higher implantation than somebody at the age of 38 giving me 10 eggs will have poorer implantation rate than somebody at 26 giving me only 4 eggs. So that's a crux, ma'am. So the poorer the AMH, the lesser the eggs, the lesser the implantation potential. That's something. But that is something we can't change about. We have to look at both the eggs and the sperm. But if your lab is consistently churning out only poor quality embryos, we need to look at from the drugs to the lab. Everything from the drugs we use, the batches, the cold chain, to how the injection is being administered, and how long they're taking the injection and walking around, to everything. And of course the lab in terms of media, the culture media, the oil, the gas that goes into the incubator, the water in the incubator, the air quality, your HVAC, everything has to be tested, ma'am. So there should be nothing left unturned when we have a series of poor quality embryos even in good prognosis patients.
Any role for antioxidants or supplements or anything you feel? I know
Sorry,
the
ma'am?
literature, any supplements would improve? I know the literature is devoid of that, randomized control trials. But in your practice, have you tried any supplements?
Yes, ma'am. In terms of when I see, whenever or any person who is going to go through an IVF, I prefer, obviously we give them folic acid, ma'am, but I prefer to put ladies with women with poorer AMH on CoQ. So that is something that I have used it. And other than that, just a multivitamin supplement. Nothing much.
Thank you. Any other questions, Dr. Chitra, Mariano? Any delegates? Because I don't see any questions in the chat box. Yeah.
Is it okay if I just interrupt and ask a question, ma'am? What do we do when a patient asks, so let's say a patient has a high quality blastocyst and a poor quality blastocyst. We're going to say, we're going to transfer the high quality blastocyst for you. The poor quality blastocyst is not suitable for freezing. So unfortunately, we will not be able to freeze that embryo. And the patient asks, why can't you transfer the poor quality blastocyst for me now and freeze the good quality blastocyst for later? Have you come across this? We have on a few occasions. Just asking your thoughts about it.
That's a very, very common situation that we do have. And if it's especially a fresh embryo transfer, we tend to use the poorer quality embryos at that point of time and freeze the better quality embryos because they can survive the freeze thaw process very well. But of course, with the vitrification, I think even I put an embryo with 50% fragmentation, I get everything out beautifully along with the fragmentation also living nicely. So, but then if it's a fresh transfer, we go ahead and transfer the poorer quality blast and then save the good one. But of course, I won't even throw out that poor quality blast. If it's got even a CC, I would still freeze them.
Thank you.
Thank you. Thank you very much. Dr.
Thank you,
Chitra,
ma'am. It's my pleasure.
Yes, ma'am.
you have any queries to Dr. Priya? We won't get her this free anytime.
I'm free, ma'am.
No, don't tell me that. Okay. Okay. Unmute. Chitra, unmute. Unmute, yeah.
Okay. It's really important to use time-lapse technology in selecting the best embryo qualities, and really is it useful to get a good clinical pregnancy rate and live birth rate?
Okay, it's a very interesting question, and then it's got a very interesting answer as well. Time-lapse has been around for a very long time, and there are many papers churned out by on that. Literally one group churning papers only on that for a very long period of time. And but when they put together all the papers, what we know that one group which it agrees on certain timeline, another group is not able to replicate the same.
True. Yeah.
So if I give a timeline and the world has to use it, everybody should be able to replicate the same results, which is not happening. So we really do not know if the morphokinetics that is churned out by the time lapse has got, we don't know yet what to use with the time lapse. But what the time lapse is great at is as an incubator, because you don't have to open it. So it is completely a closed incubator, which gives the embryos absolutely uninterrupted culture system, which has resulted in better pregnancy rates with that. So if it is finally that 85 lakhs is finally being brought down to becoming an excellent incubator.
I completely agree with that, Chitra ma'am. One of my research papers was on the perinatal outcomes with time-lapse imaging incubators. So we just put perinatal outcome time-lapse imaging and put my name, the paper will come out, and that was exactly the same conclusion.
Okay, Priya, thanks a lot. Thanks a million for your time.
Very nice.
And it is an excellent speech. So, Mariano, should we go ahead with your talk? So, to introduce Dr. Mariano, so my teacher has spoken first. Now he was my student, but I feel that I can learn many things. He can become my student, can become my teacher in future. So I know Dr. Mariano as a postgraduate, and he was so sincere, so hardworking, and so intelligent. And when he joined, his mom came to me and said that, just guide him in reproductive medicine. And then in his very first year, he attended one of the conferences in Chennai and grabbed the prize in PIS. And it is very, very nice working with him. And he has a lot of respect for the teachers, very obedient and very intelligent, that you can see from his CV here. So he had, as soon as he finished his post-graduation, he has his goals in mind, that he went for reproductive medicine in CMC. Then later, now he did his MRCOG, and now he is in a reproductive medicine specialist. He is a consultant. I am very proud of him that he has recently drafted BFS guidelines on recurrent implantation failure. So after seeing this paper, I thought sometime we should interact with him. You can see his CV here. He has published 28 papers in international peer-reviewed journals, and also he has won a lot of medals. And that is very proud to say that Cochrane author and received the gold medal in obstetric and gynecology from the Prime Minister of India in 2012. So congratulations, Dr. Mariano. This just I read in your CV. So his research work on live birth and perinatal outcomes with frozen oocytes obtained the best research paper of 2020 from Fertility Partnership. Of course, as an undergraduate project, he supervised and obtained the best poster award and for his candidate, I think. Congratulations and welcome. And it's very nice to see you here. And some of our postgraduates are also there. They also, get benefited a lot from your work. And I'm sure you will be their role models, some of their role models.
Thank you,
Welcome.
ma'am, for a very kind introduction.
Yeah.
And ma'am has given very kind introduction. It's a privilege for me to be able to present. And I wouldn't be here if I hadn't had the support of great teachers. Madam, you were incredibly supportive of me during my postgraduate days, which made me think, okay, I can achieve these things. So always incredibly indebted to you. So I'll just share my screen and start with the presentation. Now, because we have a slightly diverse skill mix of audience, the plan is to present the BFS recurrent implantation failure paper, but I will just go through a brief synopsis. And of course, at the end, if you have any questions about anything in particular, I can elaborate on that in a bit more detail. Now, Priya Kannan ma'am has discussed in detail about implantation. So I'm going to take the other side. I'm going to say what happens if implantation doesn't happen. And we do know that that is actually quite a common problem because only around 60% of people have a baby after 3 full cycles of IVF, which means 50 to 60% don't. And the first issue with interrogating recurrent implantation failure is how do you define it? Do you take, for example, we in this guideline took a positive pregnancy test as the cutoff, whereas many authors consider a clinical pregnancy to be the cutoff. But if you, and the issue comes out even about definition of implantation. If you look at the international fertility glossaries, they vaguely define implantation almost as sort of a consensus mechanism or to define it as a process rather than a single event. So it's not defined as a endpoint. The endpoint, as Priya Kannan ma'am has said, is where you have the gestational sac, but implantation is supposed to happen even after a few days after embryo transfer, once the embryo starts entering or burrowing into the endometrium. Now, we took a positive pregnancy test, and we took 3 consecutive transfers, and we took good quality embryos. And for good quality embryos, we took the definition of 5-cell CC or a day 5. We took this as the ACE guideline, which roughly corresponds to 3AB in the Gardner system. Now, the reason we took good quality embryos is, as has been discussed in the previous presentation, poor quality embryos inherently have a lower chance of implantation. So the fact a poor quality embryo hasn't implanted shouldn't be a source of unexpected news. Whereas when 3 good quality embryos don't implant, that indicates, okay, we need to look at whether there's something else here we need to examine and treat. Now, we did a literature search up to July 2019, and we based a list of topics for both investigations and interventions based on advice from the British Fertility Society Committee and by consensus between us authors. We used a traffic light system so that we can easily express what we think of a particular investigation or intervention. Red means don't use it. Yellow means you can consider, but it's very much limited. And green means yes, definitely there's grounds to use that investigation or treatment in someone who has had recurrent implantation failure. Practical limitations when we came across this guideline is, number 1, lack of a consistent definition. And many investigations or interventions have only been studied in the random cycle or the first cycle. Not many studies are there in pure recurrent implantation failure study group. Now, the other problem we faced was there was a tendency to extrapolate interventions which work in recurrent miscarriage to recurrent implantation failure. On the face of it, it both look the same. Both are failure to achieve a baby. But more recent data indicates that in recurrent miscarriage, the embryo implants but then does not progress. For implantation failure, the embryo doesn't implant in the first place. And more recent, historically, when I started off, a decade back, we were taught that the embryo burrows or implants into the endometrium, whereas we now know that actually the endometrium hugs or envelopes the embryo. So it chooses which embryos to implant into itself. And the current thought process is that in recurrent miscarriage, the endometrium is not selective enough, so it embeds both good and poor quality embryos, and the poor quality embryos miscarry. And recurrent implantation failure, the endometrium is too choosy, so it doesn't want to implant any embryo, even those which are borderline, and therefore none of the embryos implant. Now, looking at investigations, we have looked at sperm, oocyte, karyotype, adnexal factors and uterine factors, immunology and thrombophilia, and endocrine factors. We look at sperm. We looked at sperm aneuploidy. So just like you can do a blood test and check for a karyotype within a blood cell, you can take a sperm cell and check what complement of chromosomes is within it. Of course, we do know that it will be half the batch, so 23 chromosomes rather than 46. And we can use FISH to see, okay, these 23 instead of 23 chromosomes are 22 chromosomes or 24 chromosomes. But the problem is when you stain the sperm cell, the sperm dies. And so even if you identify that a sperm is normal by testing, you can't use the sperm. So because there's no treatment available, it is a test, which is a test, but you can't do anything about it. So as you know, I think it was either in Hutchison or Harrison, the first introduction used to say that if an investigation is not going to change what you're going to do for management, what's the point in doing the investigation? So because of that reason, we created it as AMBER. Sperm epigenetics is a field of growing interest. Now, there have been different tools at looking at epigenetics like protamines and microRNAs, but we still don't know whether it works in RIF. CASA, that is, instead of manually assessing the sperm analysis, can we ask the computer to assess it and provide us a more detailed report? The trouble is we don't know whether it works for RIF. In IUI, where you need to have natural fertilization, there it seems to help a bit, but especially if you do ICSI, where you're selecting the sperm manually, injecting into the sperm, and the sperm actually doesn't have to move, we don't know whether CASA makes any difference at all. Next, coming to sperm DNA fragmentation. Now, there is some correlation with recurrent miscarriage, and the American Society of Reproductive Medicine, its most recent update, has suggested it as one of the tests. But for recurrent implantation failure, we don't have enough data. And currently, none of the professional international bodies recommend in recurrent implantation failure to use sperm DNA fragmentation because we don't know it works. If anyone has any questions about how we counsel patients about this, just let me know and I'll be happy to talk through more about it. Now coming to oocytes. AMH is the only non-invasive test we have to check for egg. And even this is not a measure of egg quality, it's more of a measure of egg quantity. But it has a use. For example, if we do know that if two women are there, both of whom have had recurrent implantation failure, but one person has a very good egg reserve, the other person doesn't, we know that the person with a good egg reserve is going to have a higher chance of having a baby, purely because we are going to get more oocytes. Next, looking at karyotype. In conventional recurrent implantation failure, where you define as 3 embryos, there's no point. But in higher order recurrent implantation failure, for example, if you transfer 10 or 15 embryos, there might be a benefit. But in practice, I think it's often done even after 3 or 4, but even in practically, you find most of the karyotypes coming back as normal anyway. Now, there is some consideration to use it selectively if there's a family history of a recurrent miscarriage, in which case perhaps the yield of the test might be higher. Now, next, coming to uterine and adnexal factors. Of course, ultrasound is very useful to detect submucous fibroids, and type 0 and type 1 definitely need to be detected because we need intervention will help. Adenomyosis, till now we don't have strict defined criteria organized by any international consensus guidelines. So it's quite subjective to diagnose adenomyosis, and what one person may say as adenomyosis, other person may not agree. So because we don't have the diagnostic criteria, it's difficult to say, okay, this is the stage at which we need to define, and therefore we can assess whether it has an impact. Of course, uterine endometrial polyps, which are larger than a centimeter, it's useful to detect. Adhesions may not always be very clear on ultrasound, but to the experienced operator, you can find features. And of course, hydrosalpinges, which is fluid in the fallopian tubes, is an important factor to be picked up on ultrasound. Now, the next question comes about 3D scan, and my special research interest is in 3D scan, and it is quite good in picking up uterine septum as compared with laparoscopy and hysteroscopy. Now, the problem is, what do we do when we diagnose a septum? Historically, we thought, okay, if there is a septum, there's a higher chance of a miscarriage. But at least in IVF populations, it doesn't seem to be the case, with no difference in live birth rate noted by a recent study. Although, other studies are there which say that it does have an impact on the live birth rate by increasing the risk of miscarriage. Till we have conclusive evidence the septum does increase the risk of miscarriage, then the next step will be to do a trial looking at removing the septum, and then we'll be able to say for sure whether detecting or intervening for a septum will definitely be useful. Next, looking at screening hysteroscopy, that is doing a hysteroscopy if the ultrasound is normal. The ultrasound is abnormal, of course, you have to do hysteroscopy to remove a polyp or a fibroid. But if the ultrasound is normal, do we still do a hysteroscopy to be able to detect things which we couldn't detect by ultrasound? Well, there's 2 big studies on the subject, and there seems to be no benefit whether you do the hearing hysteroscopy before either patient's first cycle or even after 2 to 4 failed cycles. Now, endometrial receptivity array is the hot topic of the moment. Basically, the theory is that you can check the genes in the endometrium and say whether this endometrium is suitable for implantation now, or should we implant instead of day 5, do we transfer blastocysts on day 4 or day 6 if the patient has a displaced so-called window of implantation. There's one RCT, but it was for first cycle, not for RIF, so it's not really directly extrapolatable. The 50% dropout, which is a major problem, and what happened in the ITT analysis was, it turned out that just doing a fresh embryo transfer gave a better live birth rate than doing ERA. But if we take out the dropout factor, the success rates still seem to be higher for ERA, but because of the massive dropout, it's till now we have to say there's no point doing ERA at the moment unless you're doing it as a research basis. Next is immunology and thrombophilias. In uterine natural killer cells, there doesn't appear to be any specific studies, but recurrent miscarriage, there is a good amount of data that natural killer cell proportion might be different, but what do you do for intervention? We still don't know. Peripheral blood natural killer cells, the studies are quite small and they've used different methodologies. The important thing to note is that the uterine natural killer cell levels have no correlation with peripheral natural killer cells. They're completely different populations of leukocytes with different markers and everything. Next, looking at endometrial cytokines. This is another new topic which is coming up, but we really need more research. And cytokines have also been looked in the peripheral blood, and we need more data. Genital microbiome. This is also a focus of much research. There was a plan for a project in Leeds before I had left them. Till now, we have to say we haven't reached the stage of clinical application. So what is microbiome? Microbiome is basically, you check what all microbiota, that's the bacteria, fungi, protozoa, and viruses are present on a given tissue. So the thought is you can check the microbial levels in the vagina or in the endometrium, and then we can tailor the treatment. And bear in mind, these are normal bacteria and fungi. These are not infective agents. So if you have an infective agent like tuberculosis, of course you have to treat. But for the normal commensals, the ratio of those commensals, it doesn't seem to be of any particular predictive value, or even if it turns out to be a predictive value, how do you intervene? How do you change things? We still don't know whether what the benefit of that might be. Next, looking at HLA incompatibility. Previously, there was this huge thought that we check the HLA status of both partners and say whether they're compatible to each other. But now the data seems to suggest it doesn't make a huge difference. Next, coming to inherited thrombophilias like prothrombin 2 mutation, factor V laden, and so on. There's no association with RIF, which makes sense because the placental blood vessels only really start developing at the end of the first trimester and second trimester, which is where you start aspirin at the end of first trimester, second trimester, that sort of period. And so it makes sense that it doesn't have any association with RIF. Antiphospholipid antibody syndrome is a bit different because we know it can even affect the first trimester. The prevalence of RIF APLA appears to be higher in women with RIF than in the general population. And so there might be room for testing, but we still need more data. This is not enough numbers to say it's a sort of a green investigation. Next, coming to endocrine factors, TSH. Now, of course, if the TSH is over 4, every one of us will agree, let's treat. The TSH is between 2.5 and 4, it's very, very unclear. The ASRM gives 2 options, treat or monitor. There are no RCTs on giving thyroxine on 2.5 versus 4. What we have is a retrospective study. The largest one is around 5,000 women with TSH between 2.5 and 10. They found if we give thyroxine, if the TSH is between 4 and 10, it reduces the risk of miscarriage. So that's well and good. But what happens if you give thyroxine and TSH is between 2.5 and 4? There's no change in the miscarriage, but rather giving thyroxine seemed to increase the risk of preeclampsia and preterm birth. Now, again, I have to stress this is a retrospective study, but there are no RCTs, so we have to rely on the retrospective study. Now, thyroid antibody testing. The incidence of antibodies appears to be different in different studies. We don't know whether it's different populations studied and so on. And the other factor is, even if you find antibodies, as long as the patient has a euthyroid status, the TSH is normal, there's no point in taking thyroxine because the tablet study indicates it makes no difference. But in my opinion, perhaps it's yellow because we can identify the cohort of women who will benefit from annual testing, or those women who it might be worthwhile testing once they're pregnant, because we do know that in women who are having thyroid peroxidase antibodies, are more likely to slip into a hypothyroid state. Prolactin, there's some association with recurrent miscarriage, but none with RIF at the moment. Free androgen index as well, there's not much benefit of testing. HbA1c, I need to make a distinction here. There's no point in testing just because the patient has a RIF, but if the patient has PCOS or is overweight or something of that sort, then if the other risk factors, of course, it's worthwhile testing. But solely for the reason for RIF, HbA1c is not worthwhile testing. Next, coming to treatment options. Lifestyle changes, what was alluded to at the end of the last presentation, smoking cessation is something we completely recommend. I know it's not so much of a problem in the Indian scenario, but passive smoking might be an issue in the Indian scenario as well. So that's important. And we do advise the partners that smoking, one, reduces their sperm quality. Second, is going to reduce the partner's egg quality as well. There are no data specific to RIF, but we generally thought this was a good practice point. Optimizing weight. It's important to note that ideal BMI is under 25. When you're 25 to 30, your IVF chances go down by a factor of 1/10. And then when you're over 30, it goes down by a factor of additional 1/10, so total 1/5. So practical means, it means, let's say a 40% chance of having a baby, but your BMI is like 33. Instead, you're going to have a 32% chance of having a baby. So it's a 1/5 reduction. Male partner being obese also negatively affects. In fact, a few centers in UK have started restricting NHS funding, that's the public health funding, if the male partner's BMI is over 30, because male partner's BMI being over 30 also reduces the chance of having successful IVF by a factor of around 1/10. Vitamin D supplementation. There's this excellent systematic review indicating vitamin D deficiency reduces the live birth rate. But one is there's no investigation specific to RIF. We still put it as green because this was a good quality review. But it's important to note, there's no point in, patients might ask, is it worthwhile waiting 6 months? Because it can take 6 months to get someone's vitamin D levels not to normal. How much of an improvement will that make? Perhaps in someone who's in the older side, I wouldn't wait because RCTs have not shown any benefit. And in light of this, in current guidelines in the UK, is we tell them to take 400 units, maybe up to 1,000 units a day. But we don't ask them to postpone treatment just to get their vitamin D levels normal, because the RCT is still dead, or supplementing vitamin D have not shown any difference. Looking at sperm antioxidants, there's not enough data in RIF. I was a co-author in largest randomized controlled trial from India. It was published from CMC Vellore, just published recently, using vitamin C, vitamin E, and zinc. No difference in the live birth rate for men having ICSI. Hyaluronic acid binding was thought to be quite promising, which is where the HAP-SELECT trial was commissioned, found no difference in live birth rate. IMSI, that intracytoplasmic morphologically selected sperm injection. So basically, instead of looking at the conventional magnification under the microscope, I think I might be extremely wrong here because we have an embryology expert as well, but I think it's around 30x. Instead, you look at, I think, 1000x. I might be completely wrong on the numbers. But you can look at very high magnification and look at the sperm and thereby select even the best of the best sperm. Now, there was a non-randomized trial which showed an improvement in live birth rate, but RCTs are still awaited. And speaking to experts in the field, they feel that INSEE, as anecdotally in the centers which have implemented it, haven't shown any massive difference. Now, magnetic activated cell sorting, that is basically what you can do is you can sort out the sperm based on their integrity of the DNA and the cytoplasm into different routes based on these annexin 5 columns. Now, there was one RCT, not in RIF, but in egg donation, made no difference to clinical outcomes, so we have graded it as red. Next, looking at surgical sperm retrieval. Now, this has to be distinguished. We are not talking about surgical sperm retrieval when there's azoospermia, when that is the treatment to do, but rather in high DNA fragmentation. And at present, we have to say there's not enough data, so we shouldn't really do that. Ovarian stimulation. We don't have enough data to recommend any particular strategy. The ultra-long protocol was quite promising in endometriosis, but the latest update of the Cochrane review showed no major difference. Coming to counseling, counseling is useful because going through an unsuccessful IVF cycle can be soul destroying for patients, and it's important they have counseling support. And if abnormal karyotype is noted, of course, genetic counseling is very useful. Coming to embryo selection. Now, it sounds paradoxical that we are graded as yellow when most people would use blastocyst transfer to select good quality embryos, but I think it goes to show the lack of available data, specifically in RIF, specifically because we don't have cumulative live birth data, and that is the criticism of blastocyst transfer. Now, to be honest, we use a blastocyst transfer, so I'll be clear cut about that. In the lab where we work, we use blastocyst transfer routinely. But the criticism of doing a blastocyst transfer is it doesn't change the cumulative live birth rate. You're just selecting the best embryo, not making the embryos better by keeping them in culture for 2 more days. So why don't you just transfer on day 3 and freeze the rest? So that's the criticism. Assisted hatching, no difference, not to benefit, and in fact, it might be harmful. It might increase monozygotic twinning. Time-lapse imaging. The Cochrane review showed no difference in live birth rate. So for RIF, we say no. But as was alluded at the end of the last presentation, it is a very good incubator at the end of the day. Pre-implantation genetic testing, we don't have enough data to say it used to be used for RIF. Now, it's important to note that with PGTA, the live birth rate of first, second, and third FETs is good, but slightly declines. It's not massive. It's maybe 10% difference from 1 to 3. Which indicates around maybe 10% of factor might be factors outside the embryo, which is accumulating over time in these patients. So indicates might be worthwhile testing for factors in the endometrium in research purposes. Next, coming to embryo transfer techniques, ultrasound guidance is good, full bladder is good, cervical dilatation, there's not much data. Bed rest makes no difference. Fibrin sealant, people were trying using fibrin sealants at the cervix to stop the embryo coming out. There's no difference. Even cervical mucus removal, just removing all the mucus from the cervix to make sure there's no cervical mucus carried in, seems to make no difference. Antibiotics, there's no difference. Embryo glue. Now, this is one of those things where we graded yellow, despite there being a Cochrane review which showed it increased live birth rate, but because of the fact the Cochrane review did not include any patients with RIF. So in RIF patients, it makes no difference in outcomes. And personally, in our own data, both in the unit I worked before as well as the unit we worked here, the audit showed no difference. We have published the data from the previous unit I worked in Leeds as a poster, and it's going to be written up as a full paper. But at the end of the day, that's a retrospective study. So embryo glue hasn't, unfortunately, lived up to its promise, is my take-home message on that. Frozen embryo transfer. Now, this is not doing a fresh transfer, just doing a frozen embryo transfer. We don't have enough data. Interestingly, natural cycle FETs, the endometrium transcriptome analysis seem to be better in women with RIF. And maybe it's worthwhile considering natural cycle frozen embryo transfers than HRT frozen embryo transfers for women with RIF. Sequential transfer, that's transferring on day 3 and then 2 days later transferring on day 5. Not enough data. And coming to uterine factors, polyps and fibroids, definitely would advise surgery if it's indenting the cavity. Hydrosalpinx, surgery is advised. Septal resection, we don't really know. Endometrial scratch, initial data was promising in the Cochrane review. Subsequent studies not so. So practically nobody's using it nowadays routinely, maybe at patient request, maybe in some centers. At least in the UK, this is the scenario. Next, community immunological factors, intravenous immunoglobulin, we don't advise using. Corticosteroids, it was quite promising, especially for high uterine natural killer cells. Initially, it was used anecdotally a lot, but then the cohort study indicated no difference. And especially with COVID and all the immunosuppression related risks, we are no longer advocating. It's important to note that if you are using high dose steroids, that patients be given folic acid 5 milligrams per day, because the disadvantage of high dose steroids is cleft lip, cleft palate, and preeclampsia. Next, coming to endocrine factors, thyroid's already been covered, hyperprolactinemia, not much point. Empirical treatment, heparin. Then acquired thrombophilias like APLA is noted. There seems to be a benefit. Viagra, no benefit. GCSF, doesn't seem to be enough data. Platelet-rich plasma, no, doesn't seem to be a benefit in the data. And donor gametes and surrogacy, obviously, if it's a karyotype problem, use donor sperm. Just using donor sperm for high DNA fragmentation, we don't really know enough to say that is a useful option. Surrogacy, of course, there's massive Asherman's or significant uterine malformations. Surrogacy is an option. Surrogacy for adenomyosis, well, we still do not know whether it is useful. And this is the full paper. I am sorry to rush through some of those slides, but if you'd like to have a more detailed look, please do have a look at this paper. It was a work of 2 years of rewriting and revision and so on and so forth. And if you're not able to access it, please email me. I'll just leave that on for a second so that if someone wants to copy my email address, they can. And if you're not able to access the full article, please don't hesitate to send me an email. Thank you.
Thank you, Dr. Mariano. Priya, your comments?
That was a very elaborate thing, but it was very nice. Yes, I mean, what you have told is been said, but then there was this recent Cochrane, I think, by Dr. Mohan Kaman and Sunkara, where they had said that there is a very low evidence to show that there could be some improvement, or very low evidence about hysteroscopy. But even when you take into consideration, it didn't arrive at having any positive effect on implantation.
The trouble was, in Mohan Kamath is my mentor at CMC Vellore, and we had discussed this. The problem was some of the trials were, not that great quality, and there was a risk of inherent biases in some of them. And that's why we quoted the Insight and the Trophy trials, because these are, high quality, well randomized trials, good selection of patient population, and there is a very low chance of any errors creeping into and it was good sample size as well. Because the trouble with some of the smaller size RCTs is it does make you wonder, why is the RCT size? It could be just because of logistical limitations, but are there other small similar RCTs which don't show a difference, and so hence don't see the light of day? Because with all the goodwill in the world, if a study shows not a significant finding, it's very difficult to get it published anywhere. And so that was the concern. And when that's the advantage with the larger study, it takes away the small study issue. And that is why we had to say at present, if you have a good scan, and that's the other thing, it also depends on the quality of the people doing the scan as well. Subtle issues can be picked up by an experienced sonographer, someone who's had training. And the question is, do we do hysteroscopy even when the ultrasound has no problems at all? Answer to that question is no. But if the ultrasound, the sonographer says, okay, I'm not able to really say if there's a polyp or not because endometry is really heterogeneous in the secretory phase and so on and so forth, that it's a bit thicker, then I would say, okay, let's just do a hysteroscopy. The patient has had 4 implantation failures. But if the sonographer is confident saying it's a trilaminar endometrium, absolutely beautiful looking, good thickness, mid-cycle, then I would not suggest hysteroscopy for that patient. The other thing which comes into factor is the cost, because this is a BFS one is more UK oriented. I mean, the costs of any interventions here are quite enormous in the private sector, and within the NHS sector, patients will be waiting like 6 months to 8 months. So, if a 40-year-old is waiting for hysteroscopy.
Mariano, I have one query,
Sorry,
Dr. Priya also. So it is our observation when we give ovarian stimulation and monitor, sometimes the endometrium looks very heterogeneous and polypoid, localized polypoid appearance. And it is not there afterwards, after the stimulation is over. So what do you do in those cases? Do you put them in hysteroscopy just before the next transfer?
Ma'am, in generally those cases, could be just a iatrogenic thing because of our hyperstimulation.
Yes.
So probably if you can just freeze the embryos and then look at it the next cycle in a natural one or a minimal estrogen given or even in letroz cycle, we would have a better idea of the endometrium.
Endometrium, rather than subjecting them to hysteroscopy.
Yes, ma'am.
That is okay.
Yeah, Mariano and Priya, I just have 3 questions. One, how do you rule out these immunological factors which are contributing to the recurrent implantation failure, and how you diagnose? Because we might have diagnosed other conditions we would have ruled out, but I really don't know about the immunological, how you diagnose and how you treat one. Second one, how do you tackle the thin endometrium? Because in spite of giving aspirin, GCS or whatever, how do you tackle this thin endometrium? And third, when you start evaluating the male factor for the recurrent implantation failure, like in spite of 7 parameters being normal, which are the patients you think, okay, he might be contributing, like doing DNA fragmentation or going to in depth of male factor morphology, semen morphology analysis? So these are the few doubts, but it's very nice presentation you presented, Mariano, elaborately telling the pros and cons of each one and with a lot of data. Thank you so much. Yes, please.
ma'am, would you like to have a go or?
The immunology is all yours, please.
Okay, so immunological factors, ma'am, there are primarily 2 things you can test for. You can test either the endometrial level or at the peripheral blood level. Now, at the peripheral blood level, the problem is the immunological markers change day by day. Patient has a cough, the immunological markers will be all over the place. And so the practicality of that is quite limited. And it will be good to have an immunological marker in the peripheral blood, which actually reflects the endometrium, because that will be fantastic. But we don't. And that is why I made the point that peripheral natural killer cells make no correlation to uterine natural killer cell environment. They're completely different species. So peripheral immunological testing is not useful unless and until they develop a method which can actually represent what's going on within the endometrium. Second question comes about endometrial testing. The problem with endometrial testing is you can't do it in the cycle you're actually doing the transfer.
If at all you find, you did the immunological testing, how do you know, yes, she's having immunological factor? Once you diagnose, yes, she's having, how you are going to go about it?
Let me rephrase it, ma'am. The only immunological factor I will test for is antiphospholipid antibody syndrome in someone with recurrent implantation failure, because that's the only immunological condition which has been conclusively shown in studies for 2 things. Number 1, it affects implantation by affecting the trophoblast directly. And secondly, there is a highly effective intervention available, that is aspirin and heparin, which reduces the risk of miscarriage from 70-80% to around 20-25%, which is general population risk. So other than antiphospholipid antibody syndrome,
I was thinking
of
that
recommend
natural cell inactivity or paternal leukocyte inactivity, because most of the conference they present on this, you really have a doubt.
So, no, ma'am, I wouldn't recommend it. And even if a patient came with me with the result, I would say, okay, we have the result. It shows an abnormality, but there's nothing I can do about it. Okay. Because, intravenous immunoglobulin is risky. Problems have been reported. Intralipids, some centers in the UK do use intralipids. And on occasion, people say, this doctor has recommended me intralipids. And, if the 7th cycle, on occasion, I have to say, I feel sorry for them. I feel, okay, fine, we'll use intralipids, but you have to know this is a highly risky substance you're using, because intralipids have been associated with the life-threatening allergic reactions.
Oh, okay.
Sure. So, we would say, okay, this is the problem. And we have a consent form which basically says you have a risk of death. But, sometimes people say, no, I want to use it because it's my 7th transfer or 8th transfer. Okay. And then you feel, okay, fine, we'll use it. And that way, you've But that's the practical side of things. So if you're asking me from a practicing clinician, this is what I would do. But if I would recommend to a patient, no, I wouldn't. Not after the third or fourth cycle, because one, the test is not consistent. Second, coming to the uterine natural killer cell problem. The problem is in the Coventry is the biggest center in the UK doing uterine natural killer cell testing. Even they have moved from 1 test to 2 tests because they found so much variability because between 2 tests in the same woman. So a patient comes with me with uterine natural killer cell of 10%, doesn't mean the uterine natural killer cell of 10% is actually there in the cycle I'm transferring the embryo.
Yeah.
That's problem. That's the problem. Second question you asked me, ma'am, was about
thin endometrium.
Thin endometrium. Thin endometrium, I would say what her endometrium is in like a natural cycle. Because sometimes the natural cycle endometrium tends to be a bit better. Especially we don't have to suppress and things like that. And what you can do is in someone who doesn't have spontaneous ovulation, skip the down regulation. Just give them estrogen. I mean, worst case scenario, what will happen? A follicle will develop. Okay, follicle develops. You just trigger ovulation at 16 millimeter and do the transfers 5 days later. I mean, after ovulation. So, so that is one option, try to use as less medications as possible instead of giving more medications is one option. We generally don't use more than 8 milligram estradiol. Some people use up to 12 milligrams. So beyond that, I don't see a point because it only because endometrium is going to be saturated at that level with the estrogen. Sildenafil, again, as a last step before surrogacy, we'd consider using it. And the other thing is endometrium. What is a thin endometrium? So 6 millimeter is the cutoff.
6, yeah.
So, people sometimes say 6.5 is it's thinnish, but not very
Mariano,
thin.
do you have any experience of using GCSF for thin endometrium?
Not personally, ma'am. We did the meta-analysis and found the only studies were from one group and both were published as abstracts, not as full paper. And based on that, and there were some consistencies with the accuracy of the data as well, which we wrote to the authors about. And we did receive a response, which we included in the final analysis. But no, I don't think it makes any difference to use either subcutaneous or intrauterine
literature. There is some literature which supports that either subcutaneous or intrauterine GCSF improves the endometrial thickness, and contradictory results. Very few papers. So on that, that it does not improve much.
It's
so
like
there is
an
a
orphan
contradiction,
disease.
but
it's like an orphan disease, ma'am, thin endometrium, because you don't have that many numbers. One center will not have enough data. I think there is a real need, and it might be a study for one of the team in the postgraduate team as well to just look at all the studies and compare them. Because when we did the RC, we only took RCTs. Perhaps if they take every single observational study, so at least we put together the numbers and see what's happening.
True. I think in terms of thin endometrium, if there are no other risk factors that like no additions or something, at some point of time, there has been a few patients right after stimulation, the endometrium seems to just shut off. They just, for the next few months, you don't see anything. But then after gentle stimulation with some amount of estrogen, I don't usually downregulate for everyone unless otherwise there is a necessity. I don't downregulate for FETs. We do only estrogen HRT cycles or even natural cycles or letros. So after a few months, they tend to come up, but then we need to counsel the patient to be that patient. That seems to be the key.
Yes.
We also have to be patient. They also have to be patient.
That's true.
Dr. Mariano, can I request you to summarize how many cycles with how many good quality embryos you are designating as RIF, and what are the mandatory tests for RIF?
So 3 good quality embryos being transferred, I would say, ma'am. I will also take into account the patient's age, although it was not made explicit in the paper itself. If the woman is under 40 and you have had 3 good quality embryos, then I would say RIF. Investigations wise, most patients would have already had their thyroid profile checked, I would assume, by this stage. But if not, I would check their thyroid profile. Despite me saying 3D ultrasound, we don't have much data, I would still do a 3D ultrasound because you're doing an ultrasound anyway. and it might just help assess whether there is, sometimes you can get a subtle bit of information about the lateral walls of the endometrium on 3D scan. Now, I don't have published data to say that that is the problem, which is, I have to say that is no published data, that's important. But the problem is the 2D ultrasound, you look at the midline. The lateral walls is a bit more difficult to define. And sometimes in 3D scan, you can see the lateral walls a bit more clearly. And so 3D ultrasound, TSH, and I would also do antiphospholipid antibody screening, although it is graded as yellow. The reason I would tell the patient that is, although there's not enough data, it's only yield of around 9%, which is only 1 in 10 chance we'll actually find a result. But if we find a positive result, there's actually something we can do about it.
So at this point, I want to ask you, what is the experience in UK? Because here, most of the time we want a result in that positive pregnancy test. So we do start in recurrent implantation failure, even though thrombophilia profile is negative, we do start on heparin and aspirin, sildenafil, whatnot. We give everything because we are so desperate that patient pregnancy test to become positive, even HCG, isn't it? So what is the practice in, you leave alone the guidelines, evidence, but what is the practice in UK, your center?
So we don't use aspirin, ma'am, because there's some data coming out from commentary which says that giving aspirin in patient with negative thrombophilia, negative APLA, might actually compromise implantation. I think
is there any evidence for that?
Yeah, there was a non-significant reduction in implantation rate in one of the studies.
Non-significant.
It was non-significant. That is important. And we have an information leaflet which says why we don't use it. It's a different situation in a. So for that reason, we don't use aspirin. Heparin, we are always, many of our patients end up needing heparin because of other factors, the BMI or the age or the stimulation response and so on and so forth. So we give heparin for the purpose of reduction of thrombophilia risk, but heparin for the purposes of reducing, improving success rates, we don't use that much. And despite the fact I'm working in a private unit where 100% of the cycles patients are paying for, we don't use heparin as a consistent protocol. Maybe, if patient says, I want heparin, then we say, okay, let's try it. But even if you have the least amount of side effects, we stop. Because there was an issue, I believe, in just one case report, but it did come about in the US, where a patient sadly developed hemorrhagic stroke at around 8 to 10 weeks with significant morbidity, and I believe an event. And the criticism of the coroner was that heparin had been started despite there being no indication for it. So that is, the trouble.
So extensive counseling is necessary, and if the patient wants, we can start on it. Otherwise, there is no evidence.
Yeah, I mean, and it's a question of theoretical evidence versus theoretical risk, ma'am. The theoretical
same way. Are you doing natural killer tests and NK cells in recurrent? Are you recommending in RIF? Because as you said, when there is no treatment, there is no point of doing the test.
That's the problem, ma'am. So we don't do it here, ma'am. We send them to Coventry because they have the regional center which have the best. So what I would say is I don't recommend it. So first off, when the patient says,
failures you send?
So if a patient comes and says me, I have read about uterine natural killer cells, I want that, I would say I won't recommend it because there's no treatment.
Yes.
What if you find a problem? There's nothing I can do about it, and I can't say that is the same result which is going to be in the cycle we actually transfer the embryo. Patient still says I want it for sure. Then I say, okay, if you're going to have it done, have it in a reputed research center. And they have this information, fantastic information leaflet which says this is research, and that's different, ma'am, because patient needs to know it's research. So we tell them it is research, and sometimes they're happy for it. They're happy to take part in a research trial. People take part in COVID vaccine trials. Similarly, it's a research. It might help, it might not help. We also say there is a risk of, if we give you steroids as a treatment for it, there is an increased risk of cleft lip, cleft palate, and preeclampsia. Cleft lip and cleft palate we can control by giving folic acid 5 milligrams, but not preeclampsia. So you need to be prepared for that risk. So we tell them
the role of stem cells in improving this endometrium in your research. Do you have any experience in that?
no experience, ma'am. Even the research is rather limited at this stage. There have been it was a good, present. I shared this. I think it was the most watched talk around 2 or 3 years back, if I remember right. Bone marrow aspiration and extracting out the cells and infusing in the endometrium. It's a good theory. It's a fantastic theory. We haven't seen much outcome data from it though.
Just to ask, in your setup, I mean, in your practice, what luteal support would you give in a patient who's had RF? What all do you give?
So we routinely give Utrogestan 200 milligram thrice daily. Sometimes we do add in Lubion for the first 5 days after Lubion, subcutaneous progesterone, Lubion 25 milligram twice daily for the 5 days between ovulation day and the embryo transfer day. So, let's say for the,
because
if it's
you
a frozen
transfer
embryo transfer
blastocysts.
cycle, for the
So
first
you
5
give
days
like
of
25 milligrams or 50?
We get it here in 25, so we have to give it 25 BD.
25. Okay. Here also we get is 25, but now they say that it's better to give 50 a day rather than 25 a day. So just asking.
It's interesting. I mean, they are not, and that is a part of me which is a worry that they should have done dose finding studies before they rolled it out. You can't after 5 years after introducing a drug say that 50 is better than 25. That should have been done 5 years back when you did the dose finding study and figured out, okay, this is the optimal response to use and so on and so forth. But we have to go with what the data says. So 25 BD is what we are using currently, and we use it only for 5 days, so that because we think
it is before the transfer.
Before the transfer, so that the 5th day is on the day of transfer. But again, it's not much evidence based. There seems to be a theme in research now to move towards progesterone testing. But the reason I didn't bring it up is it came after we finished the literature review. That's one reason. And the second reason is I have significant doubts about it as to, what is the cutoff? People don't seem to agree on a cutoff. Is it 30? Is it 50? Is it 100? What's the cutoff you're aiming for? Sorry, I'm diverting a bit.
And in case of that injectable, just wanted to say that we also have that subcutaneous, but somehow we never had a great experience with that. We were all very excited that you don't have to use the oil injections anymore. So, but then we didn't have great results. So we all shifted back to the oil injections very quickly. So that is why the use of that has gone down, and that's why they are increasing the dose to make it 50. I'm like, one system is enough. Like, one injectable is enough.
Yeah.
So,
to be honest, there is going to be, I think I can say that in an open forum. There is going to be shortly possibly a change in our protocol once we audit our data. So we introduced this 3 years back, and the interim audit didn't show any major difference, but the numbers weren't big enough. So we are going to do a more extended audit after 1 or 2 months, and based on that result, we might either choose to use, just like embryo glue was, we do an interim audit when we introduce anything new. And you're the expert, ma'am, but as you should only change one thing at a time. So you change that, we audited it. Does work, it doesn't work. If it doesn't work, we have to go. Maybe it is to do with the patient population. Maybe it is to do with the stimulation protocol. There are so many factors which could explain why something works only in one place and doesn't work in another place. Very
well said. Yeah, so that's one. But then now there is also a shift towards injectable progesterone as well. So they're saying your bioavailability is more, so go back with it, which is what we've been doing for long. We never trusted the vaginal ones for a long period of time. So we still go ahead with that. But there seems to be a shift. So I think there's a lot of things which keep shifting back and forth, but then we are not able to find out what sometimes can actually help a patient, which is, I don't know, very sad.
Sometimes
after decades of work.
It does, and this is just slightly theoretical, so forgive me. The problem is research in itself is contradictory. So the ideal researcher is supposed to start from a point of research equipoise. So he's not supposed to be affected whether the result comes back as positive or negative when he starts off with the research. But in practice, if you start doing a research, it's because you're invested in it. You're not going to do a research because you don't care about it. So that's the problem. And what we really need is more data. And the results of the audit and so forth, I think if more and more are compiled and there is a way to share that information saying, we have done this, this is what our result is. You have done this, this is what your result is. Okay, let's see what was the difference, and we can take things from there.
Yeah,
sorry, ma'am. Chitra, ma'am, did I answer your third question?
That is about sperm DNA fragment.
I thought it was going beyond time, so I thought, okay, that's
sorry, ma'am.
I'll ask you. I'll mail you.
Okay.
Okay. Thanks a lot, Dr. Mariano, for that wonderful interactive session. And we would like to interact with you more often. Because of the COVID, you are not coming over here, but definitely when you come over here, please come and see us.
Definitely, ma'am.
We can have a in-person discussions. Thank you, Dr. Priya, for staying till the end and contributing to the discussions. Contributing to the discussion.
Thank you, ma'am.
Thanks a lot. So our ever smiling Chitra will propose the vote of thanks.
Ma'am, seriously, it was really very big on behalf of IFS Pudhi chapter. Really heartfelt thanks to both the stalwart speakers, Priya and Mariano. It was really good. I mean, after a long time, I had well, nice to hear that hi-fi topic and really coming out with a lot of solutions. Thank you so much. And I also like to thank the Shield Connect for really connecting this webinar. Thank you so much. I hope we meet frequently and just share our knowledge. Thank you so much.
Delegates.
Yeah, delegates, yes. Madam, I can't see any delegates. Okay, delegates, thank you so much for staying back. Thank you so much. I hope at least you got a grasp of what is the causes of, what are the important factors, and how you evaluate the recurrent implantation failure. So please kindly go through, update your knowledge. Yeah. Thank you so much for staying with us. Thank you. Thank you.
I would like to thank the supporters, that is Shield Connect, for making us meet and see each other and have some fruitful discussions. Thank you, Mr. Balaji and the team.
Anyway, it is live on YouTube, so we can repeatedly again see the these things, the recordings. Yeah.
Thank you so much, ma'am. Thanks a lot.
Yeah, thank
we
you,
look forward to have more sessions, ma'am, with you all in future.